Welcome to our first video on benign breast diseases. Let's begin. Here's an overview of what we'll be discussing in this lecture. We'll start with breast cysts. Here's a list of topics we will be discussing for breast cysts. Let's start with the definition. Cysts are closed, fluid-filled sacs that are common and usually benign. There are two types of breast cysts, simple and complex. Simple cysts have thin, regular lining and are completely fluid-filled. Complex cysts have thick, irregular lining and may contain solid content or debris. Here's an ultrasound image of a simple breast cyst. Note that the cyst appears hypoechoic with thin, regular lining that characterizes a simple cyst. Patients are most commonly asymptomatic. They may also present with a round, mobile mass that may be tender to palpation. Here's an algorithm that we use to guide the diagnosis and management of a palpated breast mass. The first thing to consider is the age of the patient. Patients less than 30 years old should undergo a breast ultrasound first. When a cyst is detected, determining whether it's simple or complex mandates further management. Patients with a simple cyst that are non-bloody and asymptomatic only require observation and follow-up. If the patient is symptomatic or desires further treatment, then needle drainage can be performed. Patients with complex cysts that are bloody or recurrent can undergo needle core biopsy or excision. If on ultrasound a solid mass is detected in a patient who is less than 30 years old, fine needle aspiration, FNA, should be performed. If FNA is non-diagnostic, an image-guided core biopsy can then be performed to confirm the diagnosis. In patients who are 30 or more, mammography can be performed. Core biopsy is performed on small solid masses, while large or suspicious masses need an excisional biopsy. Now let's solve this question. A 28-year-old woman comes to the physician due to a painful left breast mass. She appears well and has no fever, chills, or any other symptoms. Breast examination reveals a tender, well-circumscribed, mobile mass in the upper left quadrant. What is the next best step in management? This 28-year-old patient is presenting with a palpable, tender, well-circumscribed mobile mass in her left breast. The next best step in management depends on her age. Since she is less than 30 years old, she needs to get an ultrasound examination. If she was 30 years or older, then a mammogram would be the answer. All right, let's next discuss fibrocystic change. Here's a list of topics we'll discuss for fibrocystic changes. Let's start with the definition. Fibrocystic change is a benign breast change characterized by fibrotic and cystic changes of breast tissue. It is the most common benign lesion of the breast. The exact etiology is unknown, but it's most commonly found in women aged 20 to 50 years. It's important to note that fibrocystic change does not increase the risk of cancer. Patients with fibrocystic changes of the breast complain of cyclic, premenstrual, bilateral breast pain that improves after menstruation. Breast nodules can be present and are usually multiple and diffuse, causing irregular breast consistency. Nipple discharge may also be present. Fibrocystic breast change is a clinical diagnosis. It should be suspected in patients with classical history and physical exam showing bumpy, irregular breasts. Ultrasound and/or mammography are considered first-line after history and physical exam. Ultrasound is the method of choice for women less than 30 years of age and will show focal thickening with or without cysts. Mammography is performed on women who are 30 years of age or older. Fine needle aspiration can be performed in case cysts are detected on imaging in symptomatic patients and upon patient's request. This can be both diagnostic and therapeutic as it can relieve patient's symptoms. Finally, a biopsy can be done if the diagnosis is still not clear. This is a histological image of fibrocystic breast change. Here we can see the cystic ducts and fibrosis of the tissue of the mammary gland. Symptomatic treatment of fibrocystic change includes non-steroidal anti-inflammatory drugs and oral contraceptive pills. If present, cysts can be drained via fine needle aspiration. Warm compresses and supportive bras may also help with the pain. Patients with cysts should be followed up in 4 to 6 weeks for reevaluation. All right, next, let's discuss mastitis. Here's a list of topics we'll discuss for mastitis. We'll start with definition. As the name suggests, mastitis is inflammation of breast tissue. Mastitis occurs due to skin breakage and fissures, which allow entry of the skin's bacterial flora, most commonly Staphylococcus aureus, or bacteria from the mouth and nose of a breastfeeding infant. When bacteria enter through skin breakages, bacteria multiply and cause inflammation of milk ducts. This results in decreased milk drainage and painful breast engorgement. Risk factors for mastitis include having a prior history of mastitis, factors that impede milk drainage which can cause stasis, and/or factors that increase breast engorgement, such as weaning or a tight-fitting bra can also cause mastitis. Patients with mastitis present with an inflamed breast that appears tender, swollen, and erythematous, usually unilaterally. Patients also complain of pain with breastfeeding. They often have associated systemic symptoms such as fever, myalgias, chills, and malaise. It's important to note that mastitis can progress to breast abscess if left untreated. Breast abscess occurs as a result of severe or untreated mastitis. Symptoms of a breast abscess include those of mastitis, such as fever, a tender or enlarged breast, in addition to the presence of a soft, fluctuant breast mass on physical exam. Purulent nipple charge may also be present. Mastitis is a clinical diagnosis. Culture can be performed in treatment-resistant cases. Breast abscess is mostly a clinical diagnosis and should be suspected in patients with mastitis that does not get better with treatment. Ultrasound can also be used to aid in the diagnosis. Pain management with NSAIDs such as ibuprofen should be initiated. Adequate and frequent breast drainage is recommended. Direct breastfeeding should be done every 2 to 3 hours, using both breasts with alternating between them. Alternatively, breast pumps can be used, although considered to be less effective. Regular, adequate, and frequent breast drainage prevents progression to breast abscess. Antibiotics used in mastitis include dicloxacillin or cephalexin for methicillin-resistant Staphylococcus aureus, and clindamycin, vancomycin, or trimethoprim sulfamethoxazole for methicillin-resistant Staph aureus. A breast abscess is managed with fine needle aspiration and antibiotics such as dicloxacillin and cephalexin as first-line treatments. Incision and drainage are required for lesions that are non-responsive to first-line treatments or for an abscess that is larger than 5 centimeters. Now let's discuss an important differential diagnosis that can show up on the boards that is normal breast engorgement. Normal breast engorgement occurs due to milk accumulation without adequate drainage. It typically occurs during postpartum and early breastfeeding period, or anytime during breastfeeding, due to increased milk production. This is a clinical diagnosis, and patients present with tender, warm, and enlarged breasts, usually bilaterally, and without erythema or fever. Management of normal breast engorgement includes adequate drainage of the breasts. This includes ensuring proper nursing techniques, frequent breastfeeding or pumping, applying cool breast compresses and analgesics such as acetaminophen and NSAIDs. Symptoms of normal breast engorgement improve after adequate breast drainage. Now let's solve this question. A 35-year-old woman comes to the physician due to a painful swollen right breast. She also reports fever and feeling tired. She gave birth 2 weeks ago and is currently breastfeeding. Physical exam shows a tender, swollen, erythematous right breast. The left breast appears normal. What is the best next step in management of this patient? All right, so this breastfeeding woman comes in with a painful, swollen, and erythematous breast. Breast engorgement and mastitis should be on the differential. Because this patient is having a fever and feeling tired, and since only one breast is affected, mastitis is the most likely diagnosis. In normal breast engorgement, no fever is present and both breasts are usually affected. Therefore, the best next step should be prescribing an antibiotic such as dicloxacillin or cephalexin and advising the patient to continue breastfeeding from the affected breast to maintain proper breast drainage. NSAIDs can also be prescribed for pain management. Here's a table summarizing the conditions we discussed in this lecture. Make sure to go through each condition and be able to recognize it during the exam. Now let's solve a question. A 28-year-old woman comes to the physician due to a breast mass that she palpated yesterday. She's otherwise asymptomatic and prefers non-invasive measures. She does not smoke or drink alcohol and has no history of serious illness. On physical exam, a non-tender mobile mass is palpated in the right upper quadrant of the right breast. There are no overlying skin changes. Her temperature is 37.3 degrees Celsius. The pulse is 80, and her blood pressure is 120/70. An ultrasound of the mass reveals a well-circumscribed hypoechoic mass with a thin lining. Which of the following is the best next step in the management of this patient? A. Fine needle aspiration. B. Reassurance and follow-up. C. Core needle biopsy. Or D. Excisional biopsy. So this patient presents with a non-tender mobile mass. On ultrasound, the mass appears well circumscribed and hypoechoic with thin lining. Her age, the physical examination, and the ultrasound findings make simple cyst the most likely diagnosis. Patients should be informed that this is a benign condition with no malignant potential, and therefore the most appropriate management is reassurance and follow-up to monitor patient's symptoms. This makes the correct answer B, reassurance and follow-up. Recall that there are two types of breast cysts, simple and complex. Simple cysts have thin, regular lining and are completely fluid-filled. Complex cysts have thick, irregular lining, and may contain solid content or debris. Now let's look at why other options are incorrect. It's important to note that the management of a simple breast cyst mainly depends on the patient's wishes. If the patient is asymptomatic, is reassured, and demands no further treatment, such as the case of this patient who prefers non-invasive measures, then only reassurance and follow-up are needed. If, on the other hand, the patient remains concerned after counseling and demands further workup, then option A, fine needle aspiration, would be the correct next step. Option C, core needle biopsy, and D, excisional biopsy, are required in patients with masses that raise concern for malignancy. This patient is asymptomatic with ultrasound findings, showing a simple breast cyst. Therefore, option B, reassurance and follow-up, is the correct answer. This concludes our section of benign breast diseases.